Digital transformation in healthcare will be a very important trend and focus area to continue to provide a high-quality care over time. Ultimately, our focus is on the user or the customer or the consumer or the patient, however we want to define it. But we want a very simple and straightforward ability for consumers to find doctors, to book appointments, to check in, and everything else is done behind the scenes. But you want to start small and focus on the outcomes and the results, deliver incrementally.
Our technology partners have been instrumental over the last 2 years of helping us deliver the new models of care, be that redesigning our clinical systems or using technology to be able to remotely monitor patients, and indeed to help our staff work from home. AI and machine learning will be transformational over the next 10 years, and at our trust we'll be looking to use this technology to improve diagnostic performance, such as predicting cancers earlier and undertaking routine results for consultants.
The NHS has a huge resource in its data, and I think artificial intelligence and machine learning will enable us to really sort of exploit the potential that exists in that data so that we can provide our patients with faster diagnoses and more appropriate treatments. It's been transformative, the way in which we have been able to speed up the implementation of new solutions and the way in which we've been working collaboratively as a system. And the sorts of things I'm thinking of as we move forwards are going to be the way in which we rationalise the technology that we put in our hands of our patients.
Please welcome Stephanie Trunzo, Senior Vice President of Oracle Industries.
Well, hello everybody. So great to have you all here. Hopefully you've taken a second and pulled out your phone and started voting in our Menti poll. We like to make this a little bit more interactive than a bunch of standing heads here talking to you, so we're loving to get some feedback from you. I hope that you all had a chance to watch Larry Ellison's keynote yesterday, where he highlighted the way that we are thinking about healthcare as a really important initiative, not only for the globe, but for Oracle as well. So taking a look at this Menti poll, wow, one no. Okay, I've got to talk to you after this session. So, I'm sure that you heard Larry talk about this, and we're going to talk more about it in this session as well. But we believe that managing your health should be as simple as pulling out your phone was to take this poll. Our agenda today, I'm going to kick off with a few minutes talking about the perceptions of healthcare. Mike Sicillia, the EVP of Oracle Industries, will join us to talk about Oracle's full suite healthcare offering, how we're connecting clinical systems with operational systems, and what that means for the industry and for patients. We're going to finish with a panel where we'll talk more about seamless experiences across healthcare. It's really exciting to see the amount of energy that the technology industry is focusing on these healthcare problems. Oracle is looking to drive the changes that we all know are necessary to shift the lens of healthcare more towards the humans rather than the systems. We want to leverage our expertise to align and interlock data, but also, more importantly, turn that data into real insights and information. With that as background, I wanted to start today by understanding your perception of the opportunities in healthcare. Whether or not you work in the healthcare industry, everyone is a participant in the healthcare system. If you have a body, you have a mind, they all need to be taken care of. So what should we be focusing on, working on in healthcare most? Let's see, these results are coming in. Seamless access to all health data for patients seems to be winning, with a close second connecting the healthcare ecosystem partners. Oracle has something unique to bring to each of these areas. We have solutions that are spanning cloud infrastructure, horizontal front and back office applications, and our industry solutions. By pulling these together, these capabilities, and combining them with Oracle Cerner's deep clinical knowledge and solutions, we can really create these connection points and experiences that improve healthcare for everyone. We need partners. We need to open up the way that we develop our solutions so that it truly enables the interoperability that you hear about across different organizations and different partners. And ideally, most importantly, we need each of you, as the humans in this system, as patients, to participate. Let's imagine a different kind of future. Consumer expectations have changed, accelerated by COVID-19 pandemic. We expect to have convenient, personalized, and connected interactions at your fingertips across all of the areas of your life. Starting with convenience. Research has shown 9 out of 10 people are more likely to choose a retailer based on convenience. And 97% of people have backed out of a purchase because it was inconvenient for them. I can certainly tell you, if you make me create an account, too many clicks through a checkout process, and I'm going to abandon that cart. Personalization. 71% of consumers expect, not delight in, expect companies to deliver personalized interactions. 76% get frustrated when that doesn't happen. Research has also found that companies who excel at personalization generate 40% more revenue. It's a lot of money. Connection. As you might have heard also Larry speak about this, he reminded us, right, that shopping is easier today than managing our health experience. Retail has really created a baseline set of expectations with consumers around omni-channel, seamless transactions, the expectation for services and capabilities to be consistent across all different kinds of interactions, in person, on your phone, on your browser. So let's turn this back to you again. We talk about how we want to make sure that we're putting data in the hands of the people who need it the most, who should own it. How much insight do you feel like you have today into your personal health data? A little, none, a lot. I think that these answers really show us that we don't have the kind of understanding that we should have as individuals who should own our own health information. You have a little bit, you're not sure if you have it all, you probably don't know where to go to find it. So one last poll. If you did have access to your data, if you did own your data, would you be willing to share it with health professionals, the Department of Health, academic researchers, to really improve healthcare globally? Some yeses. If I'm de-identified, that's a big topic, right? We're willing to share our information if you can't know that it's me, but I do want the good out of being able to share the data for the globe. All right, great. Well, thank you all so much for participating, sharing some of your thoughts with us about what the state of healthcare is today from your perspective. I'm going to be back up here soon to host a panel. But first, I'm really happy to introduce Mike Sicillia, who will talk more about Oracle's plans for the future of healthcare. So over to you, Mike.
Thanks, everyone, and good morning. Obviously, we've made a very large bet on healthcare, arguably the largest that we've ever made in the history of the company. Some say it's crazy, some say it's ambitious. Nobody has come up and said, well, that looks pretty easy. So why are we so bullish about our ability to succeed and our ability to be good partners with our providers and all of the other vendors in this space? Well, one of the reasons is it's not the first time we've done this. We are running lots of mission-critical vertical edge applications at scale. And when you hear about Oracle, you hear often about database and ERP and OCI, and all those things are incredibly important and a big part of what we do at the company. But what we also do is provide vertical edge solutions to consumers, to business users, and to our customers in the sense that those applications touch our customers' customers. So today, if you've made a phone call or sent a text message which some of you are probably doing right now, that is, I guarantee you that you are somehow touching the Oracle networking technology behind the scenes that routes over 1 billion text messages and phone calls today for every major provider in the United States. In banking and insurance services, we serve over 1 billion people today. And in food and beverage, we have 350,000 sites with point-of-sale systems supporting 6.3 billion transactions annually, a lot of them happening right here in Las Vegas, right here on the Strip, because if you walk up and down the Strip and you go into any bar or any restaurant, you're likely to see the Oracle logo on the point-of-sale systems. So these are systems that are designed to deliver tremendous scale, performance, and security, and they're operational. Now, when you mix in personal health data, and you mix in clinical systems, you might think that it's not the same as running a transactional system for food and beverage, or it's not the same as running the nation's 5G and 4G LTE networks. Actually, there's a lot in common under the hood that we think is the same. And this is not our first foray into clinical systems. So today, our life sciences system, our clinical trials system, which is 15 years in operation at Oracle, is managing the largest pharmacovigilance system in the world. So pharmacovigilance, if you're not familiar, is drug safety. It's reporting adverse events to regulators. And last year alone, 91% of all vaccine adverse events that were reported to the FDA in the United States came from our pharmacovigilance system. We had over 100, as Larry mentioned yesterday, over 100 clinical trials running in the system for either COVID vaccines or COVID therapeutics. 28 of the top 30 pharmaceutical companies in the world are using our clinical systems, and one of our clients alone, one very large client alone, generated over 3 million safety cases last year using our system. So we are used to being in the clinical space. We understand the complexities of managing personal health data. We understand the security, the regulations, and all the things that come along with it, and we look forward to further integrating these systems with Cerner. When you think about the ecosystem of healthcare, we're also our popular choice on the health insurance, on the payer side of this, with over 100 million members administered in our health insurance suites today, and 200 million claims processed globally, with generating over $300 billion in premium revenue. Now, obviously, there's a tremendous amount of work here to do to connect this into clinical systems and to make all of this work more smoothly, to work all of this work at the point of care, when we should be able to determine whether or not a procedure or a medication is approved at the point of care, rather than going through the very arduous and sometimes manual process that is payer automation today. But when we put it all together and we think about end-to-end automation, this is what it looks like. We've got provider administration systems like ERP and supply chain management and healthcare management, provider clinical systems like Cerner and Clinical One, our new patient engagement system that we spoke about yesterday, payer authorization systems, and public health analysis systems, both at the national and global level. All of that can be deployed on our OCI infrastructure. And I think this is a really important fact. Our OCI infrastructure is able to be striped in a sovereign way. And when we think about data sovereignty, we often think about countries. That's not the only deployment for a sovereign cloud. Our strategy, unlike some of our hyperscaler competitors, is to build a very large number of small data centers, not a small number of large data centers. The reason is we need to get personal health information and other sensitive data as close to a particular sovereign stripe as we possibly can. That sovereign stripe could be a country, it could be a county, it could be a province, or it could be a global health system, it could be a national health system. Dedicated public clouds, dedicated private clouds that have all the same functionality and all the same security management, patching, upgrades that people are used to with public clouds. And I think that if you look at the average age of clinical systems in healthcare today, it's pretty old. It's 5, 10, not unusual to see things that are 15 years old that aren't upgraded, aren't secured, and unfortunately are a huge target for cyber criminals and bad actors today. So being able to stitch all of this together, being able to deploy an end-to-end solution is great. Being able to do it in a sovereign way is even better, in a safe and secure way, and that's our intention. So there are 5 things that we think about when we think about the future of healthcare and how we'll get all this done. The first is user-centric design. Intuitive, easy to use, joyful to use, no training required, stateless, modern. I've never heard any EHR customer use those words today when I've spoken with any of them. Obviously, there's tremendous room to improve. In fact, I recently toured a very large children's hospital on the East Coast, and the team was very gracious enough to give me a tour of the ICU and to see some of the applications in use. And obviously, it's a very humbling experience to first be in a pediatric ICU to begin with, and tremendous respect for all the caregivers there. I was stunned at how poorly orchestrated and integrated the systems were. I was stunned at the number of tablets and mobile devices and things that were all in around the core EHR system as complementary systems because the system wasn't providing the functionality that was needed. It also dawned on me that those things are also because they've been created as internal IT projects. And I heard a few times that we had a doctor who was also a computer science major who created this application for us. And that happens. And my first question was, well, who's done the cybersecurity audit on that, right? Is that an internet-facing portal? Nobody really actually knew the answer to the question. And we potentially have huge cyber risk because we've got internal compensating systems. We need to fix all of that, and we need to deliver responsive UIs, not custom UIs, not custom code, but responsive metadata-driven configuration systems. The second is collaborative and interoperable care through an open ecosystem where records are accessible and unified regardless of where they receive care and also regardless of the system that they use. We invite every major competitor, minor competitors too, to join our ecosystem. Epic, Allscripts, Athena. This is not a single vendor solution, and we're not here to take over the world. We're here to help enable the world to change healthcare, and we need all of those vendors, and I certainly hope they will, and I actually think most of them will, cooperate with us in an open way. The only way we're going to solve this is by having technology vendors come together for good. This is a moral obligation. It's not just a business obligation, and we certainly hope to see extreme cooperation from all of our competitors in the space. Efficiency across the system. Back office operations, creating better predictability and cost control. You've probably seen that the margins in the healthcare space, even for the most notable and notorious healthcare systems in the world, are very poor, if not negative. Now, COVID had something to do with that. There's no question about that in recent years. But there's a tremendous amount of money that's spent on very inefficient systems and very inefficient processes. We plan to extend our back office applications, HCM, supply chain management, core ERP, with vertical specific functions, so that in our HCM system, we can include staffing and scheduling for nurses, radiologists, ER docs as needed. In our supply chain management systems, we can offer direct procurement options so that small community hospitals can get the same negotiating power the big hospitals get to buy medical devices and pharmaceuticals. Insights that utilize modern technology to transform these systems into records of intelligence. Healthcare in general has been a lot of resistance to sharing data in healthcare. Not been exactly a stalwart of the industry. We think that our ability to secure and de-identify this data and share it, not only for the sense of just sharing, but actually giving something back to somebody who shares their data, giving them an insight would be an action that we can deliver. We've done this with the global pathogen analysis system, where we've gotten countries, even some countries that aren't so friendly with each other, to share data around variants. That data comes from a pathogen sequence, either from an Oxford Nanopore device or from an Illumina device or some kind of pathogen sequencer, where we take it, we run a computer simulation on it in our partnership with Oxford, and we determine whether or not that variant is a variant of interest, whether or not it has some form of viral escape based on vaccine or based on prior infection. We've gotten people to share data in a de-identified way that have not shared it before, and we actually have very early insights into variants in the system that we've been able to communicate across the world, which has been an incredibly humbling experience to see. I think just asking people to share data is probably not going to be as effective as saying, let me also give you a service back on top of your data and on top of everybody else's data as well. We have the technology to completely de-identify that data at the time of care, at the time that it's collected, and that's what we need to do. HIPAA-compliant endpoints, de-identified services right at the time of care, so that we make sure that the personally identified information goes directly into the electronic health record. The rest of it, if the patient consents and if the system consents, can go into global databases for good. And finally, security. I said it already. Being able to deliver this in a sovereign way is incredibly important. Unfortunately, healthcare is a huge target for cyber criminals today. It is a huge target, and lots of folks estimate that up to 30%, and I personally think that estimate's pretty light, up to 30% of community hospitals in the United States are already infiltrated. Trojan horses are sitting inside these old systems, and they're waiting to act. Now, what may seem counterintuitive is that moving all of that data to the cloud is a far more secure way to secure the system, because you have a single perimeter to defend, and you actually get the benefit of military-grade security, intelligence services around that as a service back, rather than trying to have your own IT staff manage that today. This is a scary problem. This is where cyber criminals will focus. They will focus on our utilities grid, they will focus on our healthcare grid, and we are already infiltrated. We need to get that data out of local systems into the cloud so that we can properly secure it, and we intend to do that. So again, very big bet, lots of things. We are going to embark on a series of partnerships at Oracle that you've probably never seen before in the history of Oracle, because frankly, it takes all of us to get this done. All of you, all of our partners, all of the technology vendors in the space. We look forward to playing a humble part in making that happen. So with that, speaking of partners and speaking of others, I'm happy to welcome Stephanie back, who will introduce our panel.
You gonna sit? Hello again. So we're going to have a panel joining us up here on stage. Global spending on health exceeds 10% of global GDP. Total health spending is above 40% in low and middle income countries. So I'm going to call out my panel here to talk to us about how do we solve a problem that is a very expensive problem in this industry. So please, I'd like to welcome Chris Sacinski, the Vice President, Business Applications for Atrium Health, Matt Cybulsky, founder and consultant of Ionian Consulting. Mike Sicillia is going to rejoin us on stage, Executive Vice President of Oracle Industries, Sonny Singh, Executive Vice President and General Manager for Oracle Financial Services Industry. Please join me. Thank you, everybody. So glad to see you up here. So, as I said, we know that this is an extremely expensive problem for this country, for the world. I'd love to hear a little bit, Matt, from your perspective on how do we start thinking about solving this problem?
So, thanks for having me, by the way. It's good to be here. So, one of the first things that comes to mind is that transformation right now is absolutely critical in healthcare. I think if you speak to anyone who's here at this conference who may not be from the West, they look at the US healthcare system and say, this is a little bit off, there's some changes that need to be made. Now, these changes are being discussed today on this panel, but there's also a large acceleration happening in healthcare, and one of those reasons, of course, and it's the big elephant in the room, is the COVID pandemic has taught us that patients, because of that need, are interested in being participants in their care, but they're also open to accessing care at their doorstep. Something that a lot of firms and enterprises and also health systems and insurers have recognized as well. That comes with a lot of benefits. Those benefits are safety and quality, convenience, but also transparency. So how is my care rendered? What is an ICD-10? What is a CPT? How do you take care of me with this particular disease that I have? Hallmarked recently by the No Surprises Act, which is really interesting to me, for patients and for the public to get a better sense of how care is rendered to them. I think these are really good starts, some of them chosen, some of them not.
Yeah, that's great. I mean, thinking about some of the things that you just spoke about, there were so many challenges during the pandemic, and a lot of our new perspectives on healthcare, while there were a lot of challenges, really is a silver lining coming out of this pandemic. I think I would love to hear a little bit about how Atrium, fellow here North Carolinian, how you're thinking about that and sort of what happened during the pandemic for you. How did you keep accelerating throughout the pandemic?
Sure, so a little bit about Atrium Health. We're a large nonprofit healthcare organization based in Charlotte. We support the Carolinas, Georgia, and Alabama. We service about 42 hospitals right now across those regions, do about $12 billion in revenue, and we have about 75,000 employees. But what's interesting about Atrium is just a few years ago, we were about half that size. So Atrium was really growing, and because of that, we needed to decide to start our ERP transformation journey for all of those markets coming together on one ERP cloud ecosystem. So that's when we made our decision to move forward. We picked Oracle because that was the right answer for us for all of our needs across HCM, payroll, finance, and supply chain. And then we brought Deloitte in-house as our SI partner to kick all that off. Our project was an 18-month project. We kicked off the project in August of 2019. And a few months in, well, I'll say this, and our go-live date for our first market was supposed to be January 1, 2021. A few months into the project, COVID hit, and everyone got scared. We weren't sure what was going to happen to our project because we were all patient-facing at the time, and we needed to be. But to our executive council's credit, they felt that we've got good momentum. This is the right thing to do. We need cloud more than ever because we need answers, and we need answers faster than we ever needed them before. So they told us, if you guys can make it work and keep going, we're going to support you. So we figured it out. We talked to Deloitte, and we said, everyone who was going to fly in for these training sessions on site in our training facilities, we sent them all home. Everyone's working from home. Can we do this all remotely? Atrium had never attempted anything like that before. I asked Deloitte about it, and Deloitte said, we've never done it that way either. It's a first for everybody. But we did it. We pivoted overnight, and we got back to where we needed to be. And we actually saw benefits in that virtual model. I think we were innovative in how we used the IT we had to get people in a room when they couldn't be in a room virtually. So that got us on track. We went live on January 1, 2021, just as scheduled. So even COVID couldn't get us off schedule.
I mean, we chatted a little bit about this before this session, and I think one of the things that struck me is we spend a lot of time talking about the patients being at the center of the model. Putting patients at the center of the model, putting humans at the center of the model, isn't just about the way we think about the technology and the portfolio, it's also about the change management and the processes and the people that are part of all of those, driving those changes like you just described, keeping the momentum. I think more than anything, and I'd love to hear your thoughts on this, but it's not only the change management process, but the change leadership. Mm-hmm. The role that, as you said, that the executives played in continuing to make that choice to keep the momentum of the technology projects going, despite the challenges that COVID was facing and moving towards a more virtual kind of model.
Right.
Yeah, how did people respond to that, and how would you say that change leadership really impacted your ability to accelerate so that you could go live in 2021?
So the Executive Governance Council led it all. They were intact from day one, and they were cascading all those decisions down. So that made it a lot easier. We did include in our project team a dedicated change management team that owned the change, the communication, the documentation about how your life is changing when we move to this new position. So that, coupled with the communication channels that we have in place at Atrium, got to a point where people were able to absorb the information, understand what this meant for them, and was led to a successful deployment. I will say Deloitte played a big role. They brought a lot of thought leaders. You think about an SI partner, some of it's manpower. You just need more people in the shop to do the work, but a lot of it is leadership from a know-how perspective, best practices. They brought that to the table. They educated us. And then we're also leveraging Oracle's priority support team. So when we made our purchase from Oracle and decided all the modules and SKUs we wanted to purchase, one of them was priority support. We didn't have to buy it, but we saw the value of it and we bought it. And what that allowed us to do is have a dedicated Oracle. We've got an account team, everyone has that, but we've got a dedicated Oracle technical application manager who really acts as a referee for us. Oracle's a really big organization, and when you deploy something very wide and deep, like an ERP full suite, there are thousands of different Oracle people you need to talk to on any given day to troubleshoot when you have issues, to understand roadmaps, all that kind of thing. The TAM, the technical account manager, really played a good role to understand, here's how Atrium deployed what they deployed. When this question is raised, that TAM can go get the right people from Oracle to the table, so we don't have to figure that out. We can focus on the work and the problem solving, but they're bringing the right resources to bear and managing the escalation process, and we've leveraged them immensely over the last 2 years.
So thinking through at the beginning, all of the people that you're going to need to be part of this change and making smart choices about who you include as partners, how you build out that overall process and change management. Yeah.
That's right.
Yeah. So, you know, we talked kind of obvious when you're talking about healthcare that you're going to speak about clinical systems, but maybe less obvious in some of the things that Mike spoke about. We're really pulling back office together into that conversation as well, which is why these discussions around ERP is just as important as the clinical system discussions. When we think about taking these silver linings out of the pandemic and the things that we've done to accelerate, I would love to hear, Mike, maybe you could share a little bit more about what we did from an Oracle perspective to accelerate our contributions during pandemic as well.
Yeah, sure. I think two things that stand out to me as perhaps forever changed for good are based on the work that we did with both the CDC and the NIH. So for the CDC, we created the vaccine adverse event reporting system, which was made available to the general public. So today, adverse events vaccines, or prior to this, the only vehicle to report adverse events around vaccines was through the VAERS system, which is disintermediated by providers, meaning that the patient themselves do not report it. They can, but it's really kind of clunky and difficult to use, like a lot of systems in healthcare. And often, by the time the provider has the time to actually enter it, it's maybe several days or even weeks after the adverse event actually happened. So we worked together with the CDC during the pandemic because there was a huge fear that as all of these vaccines were rolled out, there would be lots of adverse events, and there potentially could be lots of adverse events that were falsified by people who had a different outlook on vaccines. So we created for the first time a direct patient-facing system, which is vSafe, meaning that anybody could opt in, but you have to sign in. You have to have an email address, you have to have a phone number, because we were concerned about fraudulent data. And we collected we're over 155 million records today, still collecting around either an adverse event or lack thereof, which is also very, very important too, because the current systems today are only focused on adverse events. They're not focused on lack of adverse events. Then it's often it's difficult to really look at the data and say, we had all these adverse events, but how does that compare to the general population? How many people actually received the vaccine? We also have no national vaccine database in the United States either. Everything is disintermediated around 96 different jurisdictions today, literally 96, that administer vaccines. We've rolled all that up into a single system. We rolled all of the adverse event reporting into a modern stateless web application that requires zero training, and we're able to get to the point where we use that real world evidence for the first time ever, patient reported outcomes to supply evidence together with the CDC to prove that the vaccines, the mRNA, specifically the mRNA vaccines, were safe for pregnant people. Now, they're taking that same system and rolling it out for monkeypox vaccines. I expect that direct communication between government and patients will become the new norm because technology has enabled it to happen. Secondarily, as we had many vaccine trials running in concurrently at the same time, there was the sort of age-old problem of saying, are we going to get enough diversity into the vaccine trials? I mean, number one, people don't participate in clinical trials at a rate above 3%, which is the first problem. Number two, certain cohorts of patients are often woefully underrepresented in trials. So we worked together with the NIH through the Fred Hutch Institute in Seattle to create a national recruiting and electronic pre-screening platform for patients. And we pre-screened over 650,000 people who volunteered for the then Operation Warp Speed clinical trials. Not only did that system meet the diversity and inclusion goals, but actually doubled the diversity and inclusion goals into the COVID vaccine. So we had a situation when the vaccines were approved, or even on emergency use, we knew that we had, hugely amount of statistically significant data that proved that diverse and inclusive populations were included. And I think that's forever changed. We now have taken that same system together with NIH, and we've rolled it out for a brand new series of HIV vaccine trials that are happening based on that same mRNA technology using electronic pre-screening. And I'll stop with this nugget, but in that HIV system, which has been rolled out since April, the electronic pre-screening, when you combine that with targeted recruiting, today, 88% of the people that have volunteered for an HIV clinical trial have actually become eligible for the trial. 88% of people. I mean, usually 8% would be good, right? But 88% of people are now, because of targeted advertising, targeted marketing, are being placed into mRNA-based clinical trials for HIV. And finally, they're being placed into global trials. These are no longer local trials. These are trials that are happening concurrently all over the world, even if they're by different providers and different CROs. The data is all being aggregated for the first time ever to the NIH so that we can see the effectiveness. So I think those two things, I hope, have forever changed.
Well, and I think what's so great about these particular examples are that we proved how quickly we could roll out technology, vSafe 68 days. We could do it in a way that was safe and secure. We really proved to ourselves not only could we deliver rapidly, but Mike, as you're saying, taught ourselves even that this is an ongoing change that we can make. We learned how to operate differently in the world as a result of this catalyst. So let's broaden the aperture of the discussion a little bit, and I'd love to hear, Sonny, from your perspective, how do we think about this from the payer side of the story?
Sure, absolutely. So I think speaking of silver linings from the pandemic, I think one of the things we saw come out is a complete exposure of our lack of preparedness, and also, frankly, the difference between the cost of healthcare delivery and the amount of coverage that exists in the marketplace. So that gap is north of $600 billion as estimated by many insurance companies. So that's the size of the problem that's facing us right away. And interestingly enough, a lot of that is stemming from inefficiencies in the healthcare system, administrative inefficiencies. So many of you, with the possible exception of one person, was at the at the Larry Ellison keynote yesterday, and I think you might recall him talking about the pre-auth process and how inefficient it is. Let me quantify that for you. So there was a pre-pandemic study in 2019 by the Journal of American Medical Association, or JAMA as it's called, by people in the industry. And just some statistics about the pre-auth process. So in that study, they stated that the cost of doing a pre-auth for every single pre-auth is $10.23. And if you look at a process that's automated, that cost drops down to $2.83. So there is a potential saving through automation of $7.28 every single time. And you can think about every hospital system for every patient on a daily basis making thousands and hundreds of thousands of these requests. That's a huge opportunity of cost savings. The same thing applies for things like billing inquiry, for a claim status inquiry, for an eligibility inquiry. All of these are just huge opportunities to just eliminate from an administrative perspective. The same study pointed out that there's about $265 billion worth of administrative waste in the healthcare spend that we have. $265 billion. Imagine what we can do in terms of coverage and improving outcomes. So the reason why we are really excited right now is with Cerner coming in and merging with Oracle, we have a tremendous opportunity to solve for some of these really big challenging issues. The pre-auth is just one example. We could look at collapsing the entire revenue cycle management between the payer and the provider and eliminating the need for things like charge integrity and payment integrity. Imagine that we could make population health capabilities, a Cerner, available to all the payers out there and help them manage chronic care. And if you really think about the holy grail of healthcare consumers, it is real-time adjudications. You show up at the office and you can, at point of care, get an immediate estimate of what your actual cost exposure is going to be when you're receiving that care. That point of sale, real-time, or point of care, real-time adjudication doesn't exist in this industry today. All of that are possibilities for this combined nexus between the provider systems and the payer systems. And frankly, the last point I'll make here is this is becoming even more important because you see hospitals starting to take financial risk. They are starting to take on different payer models, and you see that in a number of hospitals. Similarly, there's a number of payers that are actually entering the healthcare space. So you saw Humana acquire Kindred, you saw Centene acquire Magellan, you saw Elevance get into the behavioral health space. So now you're seeing these two spaces converge, and I think Oracle is so well positioned to bring together these vastly different systems and free up a huge amount of opportunity that can then be turned towards creating better outcomes and really driving down the cost of healthcare for every country.
The claims adjudication real time is such a wonderful example of how we need to think about some of those consumer concepts that we talked about earlier. People want that immediate convenience and they want that transparency of understanding. So maybe to kind of pull this panel together, Matt, could you share from your perspective, looking across the industry, how are technologies like AI and ML going to enable us to really make good on these promises?
So I think the best way to sum this up is connecting business systems with clinical systems is a force multiplier for healing and care. Anecdotally, I had a conversation yesterday with a leader from Oracle, and he was telling me about a project they were working on for nursing staffing. For those who work in healthcare, nursing shortages have been problems. They will continue to be problems. They're likely not going away. And in his conversation with me describing how we're helping this hospital health system deal with nursing staffing, he made the phrase to me. He said, what we're trying to do is make sure we know who's closest to the patient. He meant that technically and physically, but I heard that metaphorically. Who's closest to the patient? Over time in healthcare, we've had visits with our clinicians 4 times a year or less. The idea that we're in a future that you can be inpatient and we can have a business system connected to a clinical system, making sure that there's a body and a real human next to a patient in optimal times, increases healing, has real metric outcomes for length of stay, has important outcomes for satisfaction, and integration into the care that patient's receiving. If you're inpatient, you're pretty sick. But if you have someone with you who's coaching you, who's next to you, that's a win. That, to me, encompasses, I think, where this is headed. How is that accomplished? AI, artificial intelligence, machine learning, but also will. The desire to give good care to good patients at the right time using available tools. The win is making sure people know that that's available to them. But that really sort of warmed me to hear that. And he and I had a chuckle, right? Because he was so into the weeds technically about it. And I was like, man, this is great. I'm going to write a story about it, but better or not, I'll just share it here. So to me, that sums up what I think is so important. I think also Larry shared yesterday about a cancer AI module that reduced oncology patient visits to the ER by 33%. Remarkable. I would love to hear more of those over time by connecting AI, machine learning, clinical systems, business systems for the real human narrative of healing, and I think that's success. Also, I want to know, what is the strategy?
Yeah. Well, what's interesting, I think, about that final comment, and I'm glad that we were able to save you from writing a paper here on stage here today, but I do think, this panel fully represents our philosophy that you can't just tackle a piece of the problem. Whether it's back office, whether it's ERP systems, whether it's how we think about patients, whether it's the changes that we want to make around processes that we learned during the pandemic about how to accelerate, the payers that are going to help us with that kind of real-time kinds of concepts to bring transparency to the end user, to the humans. I think that is fundamentally the strategy, that we can't look at this piece by piece. You need to really look at it holistically. So with that, I want to say thank you so much for all of the panelists who joined today. I know we wish we had more time. We could talk about this for hours. I would like to ask all of you here in the audience to take a minute and go visit us on the expo floor. Go take a look at the demos that we have and learn a little bit more about what we're doing. And please follow us on social. We're going to continue updating all of these great topics and where we head with Oracle. So thank you so much for being here today, and hope to talk to you all after the session. Thank you.
Thank you.